All right, everybody. This is emergency vent management, and this is going to be for the LTV 1000, 1200, and the Revel, and actually probably the NV as well. Um, I'm Justin Mizuraka. I'm the program director at a respiratory therapy college. I teach mechanical ventilation, and I've done this lecture for multiple transport agencies across the region. This is a ventilator that these are ventilators that we spend a lot of time transporting critical patients with. So I want you to get comfortable with them. And the reason why I want you to get comfortable with them is with this whole COVID-19 stuff, where you may be pulling these out and using these. Some of these might be in the cash systems, and then also some in the stores and your hospitals if you have them. So let's get going. Good afternoon. This is Justin Mizuraka. I am a respiratory therapist, a respiratory therapy instructor for mechanical ventilation, and also a program director for a respiratory therapy program. I just wanted to talk to you guys about emergency vent management. This is going to include the LTV 1000, the 1200, the Revel, also the NV on there as well. We're going to be talking about this, and there's a really good reason why this has come up now with COVID-19. These are the ventilators you might be seeing coming out of storage, coming out of cash systems for the federal government, and it's something that you want to be comfortable with. There's a lot of people that use these as home vents as well for the LTVs. So getting comfortable with it isn't going to hurt you in the future if you never use it for this situation. So let's get on into the slides and see what we can learn. All right, everybody. This is Justin Mizuraka. I am a respiratory therapy instructor at a associate's degree college. I've been. Good morning, everybody. This is Justin Mizuraka. Fuck me. Why is this? Good afternoon. This is Justin Mizuraka. I am a respiratory therapist, a respiratory therapy instructor for mechanical ventilation, and also a program director for a respiratory therapy program. I just wanted to talk to you guys about emergency vent management. This is going to include the LTV 1000, the 1200, the Revel, also the NV on there as well. We're going to be talking about this, and there's a really good reason why this has come up now with COVID-19. These are the ventilators you might be seeing coming out of storage, coming out of cash systems for the federal government, and it's something that you want to be comfortable with. There's a lot of people that use these as home vents as well for the LTVs. So getting comfortable with it isn't going to hurt you in the future if you never use it for this situation. So let's get on into the slides and see what we can learn. All right, so let's talk about some goals related to mechanical ventilation. If this is something that you're not very comfortable with yet, you want to know that managing a patient on a mechanical ventilation is the desire is to keep them as comfortable as you possibly can. So getting them to be able to trigger the ventilator in a way that's sensitive enough for them so they're not anxious. If they're anxious, they're going to need sedation, they're going to need paralytics, and we don't want that because if we increase their sedation and give them paralytics, it's going to increase the length of stay in the hospital. Right now, we need those ventilators, and we want to make sure that the patient gets out of there as soon as possible so they don't have a nosocomial infection that causes them to get even more sick. So let's make them comfortable and let's keep them safe. Think about our VAP programs, and we'll talk about that maybe in another lecture about decreasing ventilator-associated pneumonia. But this one we're going to hit on a little bit and move on to the next slide. All right. So we're going to make sure that we're treating our patients like we would be in the ICU. So when you think of those things, we want to think of 6 to 8 mLs per kilo, so milliliters per kilogram, no longer cc's. We want to think about oxygen, what level that we're going to put them at, how our FiO2 could positively or negatively affect the patient. We're going to talk all about that in a little bit. Attempt to get the patient to the receiving hospital alive and in better shape than when we picked them up. So this is transport related, and we want to start to decrease the amount of days that that patient has in the ICU. Again, the longer they're in the hospital, the sicker they have the potential of being. We don't want to get them infected with anything else. With the mass chaos, with everything going on, we want to make sure that we are limiting those things. And I'm going to start this stupid ass thing over again. So some of the other goals that we have, if this patient were to be transported in, we want to think of things like, I'm going to skip to number 2 right off the bat. Let's stop this for a second. All right. We want to make sure that we're beginning to treat our patients like they're in the ICU right away. So having different policies and procedures outside of the hospital might not be the greatest idea. Sometimes they have to be that way, but if the more we can get them on the level of what the ICU would be treating them would be great. That's why sitting with a well-versed practitioner and learning from them will get you to be a better therapist yourself. We want to attempt to keep the patient alive and doing well and get them in better shape than they were when we picked them up. Say we're out transferring a patient from one hospital to the next. One, we're going to make sure that we're protecting ourselves as much as we can, and then also making sure that we're doing those things that would the receiving hospital is doing, not the sending hospital, but the receiving hospital. The sending hospital might be sending them because they don't have enough equipment or they need to escalate in care, but the receiving hospital is the one that should be dictating the settings on the ventilator, the management of the patient. And we want to start to decrease the amount of days the patient will spend on the ventilator and the amount of days they'll spend in the hospital by giving good quality care, making sure the patient is as safe as possible and not causing any more infections than they might already have. So this is where we're going to do ourselves a big favor. We want to make sure that we're doing our vent check ahead of time. We're checking our circuit for leaks. We're make sure everything is functioning the way it should be before we actually put the patient on. There's been too many times I've gone to check to see if I can help a transport team assess their ventilator because they're not understanding what's going on and I always think it's the patient that's causing the problem. But if there's a leak in the system when you are turning it on, you will always continue to think it's the patient that has the problem and not necessarily the ventilator that has the problem. So do yourself a favor, check the equipment, check for a leak by doing the leak check. You check to see if all the lights light up and the noises that the ventilators are supposed to make are doing what they're supposed to. If you do have a leak, make sure you start from one side of the circuit and check for that leak that way. A lot of times on these ventilators, the connections are the points that they have a leak. So we backspin those, the flow sensor and the pressure sensor. If you backspin those before you put them on, it has this positive pressure against keeping that circuit tight. And you want those things to be tight on there because you're going to flip that ventilator back and forth when you're moving a patient either outside the hospital or going to CT, MRI, when X-ray comes in, whatever you're doing, you want to make sure that they stay nice and snug. If it senses a leak, you'll see immediately a massive amount of tidal volume going through there. It's not actually receiving that tidal volume. The flow sensor is just increasing flow to the system. Remember, flow times I time equals tidal volume. So with that flow going by to make up the difference, that leak, it'll make that number look huge. The most common places that you're going to see a leak are those connectors, and then also the PEEP valve is easy to crack on those things. So make sure that thing is attached and it's not cracked. And then anytime you're doing a check on a circuit to make sure it is working, you want to make sure you're doing it with everything that you would have in line. If you're using a viral filter or HME or a humidifier, you want to test the system with that in place. All right, next slide. All right, well, I already mentioned that other stuff about making sure all those things are in line when you're testing the system. But also, you should make sure the ventilator is plugged into a power source when you're doing that. You're just going to get the best results that way. And then also, if you're going to be transferring back and forth, don't trust that internal battery, the length of it. We don't know how long ago that had been swapped out. You're going to have an external battery hooked onto that. Just to make sure you're not going to get yourself in trouble. Once you hit that internal battery as the last bit of electronics that you have, you better make sure that thing's plugged in, or you find a power source right away. Make sure your bag is ready for you. All right, for those of you who are not well versed in mechanical ventilation modes, a little bit of history. Controlled ventilation. This is what we used to use with anesthesiologists, docs a long time ago, back before we had a good understanding or the good capabilities of ventilators to manage a patient and allow them to do the most of the work. Controlled ventilation, and we call it like the God mode. The patient doesn't have a choice of what they're doing. They get a rate that's set, a volume that's set, PEEP, FiO2, and that's what they get. And you get what you get, and you don't throw a fit. There's no sensitivity. The patient can't trigger the vent, and they get everything that anesthesiologist is giving them. If they want more, the anesthesiologist is going to realize they're waking up, and they're going to sedate and paralyze more, so then they can control that ventilation. Again, look at it like the God mode. All right, so it's this control mode of ventilation. It's used by respiratory therapists and MDs in the hospital all the time. It's a very common, very frequent mode that we use. The patient can trigger a breath, but only gets the volume that the provider sets for them. So say I'm setting a 500 ml tidal volume, which would only be the appropriate volume, which would be 6 to 8 mLs per kilo for most patients. A restricted patient, a little bit smaller tidal volume, but you want to make sure you're using your ideal body weight for that patient as well. So that the patient can take a breath, more breaths if they want to, but what they're always going to get is that 500 ml tidal volume that was set. So everything else is set for that patient, but they can increase their minute ventilation. Remember, minute ventilation is tidal volume times respiratory rate. So if they're taking more breaths of that tidal volume, their minute ventilation should go up accordingly. But The other thing, so I can hear my kids talking in the background. The other thing is they can never go below that respiratory rate that's set, and or that tidal volume. Most cases. All right, this would be the second recording of what is assist control. My kids interrupted me while I was talking. So assist control ventilation is used by most respiratory therapists and MDs, whoever's setting up the vent. That mode of ventilation is designed to get the patient a steady minute ventilation. Remember, minute ventilation is the tidal volume times the respiratory rate. The patient can trigger a breath, but every time they go to cycle a breath, they're going to get that same tidal volume that was set. So say I have a 500 ml tidal volume, which would be, I'm only going to set one that's appropriate to that patient's ideal body weight times 6 to 8 mLs per kilo, or in a restricted patient down to 4 to 6 mLs per kilo. So that the patient's getting that breath, and every time they take a breath, they get the same 500 mLs. They can breathe as many times more than they want, over what was set, but they're always going to get that 500 mLs. But they will continue to get that same volume, the same I time, same sensitivity. So when you think of the I time problem, as the patient starts to breathe over that much more, then we start to impede or cause problems with their I time, because that I time is going to take up a set amount of time in that cycle, for that cycle, so that we're going to start narrowing the amount of time that the patient can exhale. So that's something we have to be careful with. So this one's for my respiratory therapy students. IMV, the patient can breathe over the vent if they like to, but they only get the volume that they can generate when they take a breath. Now remember, they have an ET tube in, so the ET tube is going to decrease the actual foramen size of their airway. There's a piece of plastic in there that is or polyvinyl chloride in their airway that decreases their foramen size. As we decrease the foramen size, resistance goes up. As resistance, if that foramen size would be narrowed by 50%, we'd have a 16-fold resistance, or 16 times the resistance in that airway. So that would make it really hard for that patient to take a breath. And our goal is to have them be able to take breath and generate a volume, but we're causing anxiety. We're causing increased work of breathing for that patient. So maybe it's a good idea to not put them on the IMV, which is the reason why that mode is not on any of the newer ventilators. Yeah, interesting stuff, right? All right, synchronized intermittent mandatory ventilation. Holy moly, that's a mouthful, right? So SIMV, and we're is a mode of ventilation. We're going to allow the patient to breathe as many times as they want on their own. They can generate whatever they want to generate on their extra breaths, kind of like IMV. But the difference with this, we're going to give them pressure support. So what pressure support is, it's a pressure that supports the patient. That's pretty novel, isn't it? So that pressure, as we increase that numeric value, so it'd be, say, like 5 centimeters of water pressure to 10 centimeters of water pressure, we're giving them a increased pressure, which can generate a larger volume, so they can take a bigger breath on their own breaths. So they'll have their set breaths. So I had a rate of 10 on there. They're breathing 10 times, and say the volume was 500 mLs per breath that we have set for them. If for 10 breaths, they're getting that 500 mLs. In between those breaths, the ventilator will allow them to take those breaths without without being impeded on, right? So then it's not going to cycle another breath while that patient is in their breath phase. So that keeps the patient from stacking breaths. So if they were in their own breath pattern and they were generating, say, 300 mLs, we wouldn't want the ventilator to step on that breath and give them another 500 on top of that. We want it to wait. And depending on the algorithm of that specific ventilator, the patient will be able to finish their breath, or almost completely finish their breath, before the ventilator cycles another breath. All right. IMV, intermittent mandatory ventilation. So, what this ventilation mode does is it allows a patient to take a breath. It's going to have their regular generated breath. So, say we're going to use this example throughout the whole lecture, a set rate of 10, and their volume is 500 mLs, right? So, 10 times they'll get a breath cycling. Dang it. Alrighty. Intermittent mandatory ventilation. What this mode does is gives a patient a set amount of breaths. So same thing like control, or very similar to control, but there's going to be a little variable I'm going to hit on in a second. So let's just use this example. We're going to use this example through the rest of the lectures. The ventilator, we're going to say, is set at a rate of 10, and the volume is set at 500 mLs. That rate set at 10 will allow 10 breaths a minute at 500 mLs a time. Now, the patient in this mode can breathe over the ventilator if they choose to. The difference is they will not get assistance on that breath at all. It's not going to generate 500 mLs. It's going to generate only what they can generate. Now, think about the breathing tube causing a increased resistance. You have a piece of polyvinyl chloride inside the airway, which will decrease the foramen size. As it decreases the foramen size, resistance goes up. So it becomes more difficult for that patient to take a breath because the airway is narrowed, right? So they're trying to take a breath, but they really can't create the same breath that they'd be able to breathe if they didn't have that breathing tube in. And there's no assistance that allows them to take a breath. Well, here's the big dangerous caveat to this mode of ventilation. That patient is, when they're cycling their breath, they can they'll get that whatever volume they can generate. So say they generate 200 mLs, now the ventilator cycles time cycle, and it's giving 500 mLs. So that 200 now goes to 700. So we don't want that to happen. So that's why we're not using IMV. But it's good to know where we were so we can know where we're going. All right, on to the next one. Where is my, dang it. Alrighty, here we go. SIMV, synchronized intermittent mandatory ventilation. Now, here's the interesting part about this mode. What that does is it synchronizes the breaths of the patient's breath along with the mechanical breath. And so it sounds a little confusing when you first start talking about it. But remember, IMV, we were talking about that the patient could take a breath and then the ventilator does not care. It's time cycled. So every 6 seconds, it's going to deliver a breath. Because we said it was a rate of 10, so 10 goes into 60. 6 times every 6 seconds we cycle a breath. So if the patient decided to start taking a breath at 5.5 seconds, the ventilator doesn't care and it would step on their breath. Well, synchronized intermittent mandatory ventilation synchronizes the ventilator. So if it sees you or feels you or senses you taking a breath, that the ventilator will not add its breath on top of your breath. So that's a really nice safety feature, right? It protects the airways and decreases the likelihood that ventilator is going to step on the patient's breath and add too large of a volume to their breathing pattern. Oh, pressure support. Oh, how we love thee, right? The pressure support we just talked about is, interesting enough, it could be a mode in itself, or it could be an adjunct to another mode. So you can have a pressure control breath along with pressure support. Or you can have a volume control breath along with pressure support. Or you can have its own mode where you're just doing pressure support, PEEP, and FiO2 are the only things you're really setting on it. Well, a couple caveats to that. But that would be the majority of the things that you're setting on there, and the patient actually breathes on their own, their normal breathing pattern, and they get the volumes that they're hopefully that they want. They're taking their breath and they're getting some assistance to overcome the resistance of the ED tube, or allow us to give a larger breath for that patient to meet their pH balance or their CO2 removal. All right. Next one. Hey! I'm recording a lecture, and every time you do that, I gotta start over. All right, so again, pressure support can be its own mode, and it can be an adjunct to a mode. So one of the things to think about now, hopefully the majority of these things you won't see any of them, but your LTV 1000 has an external PEEP drive. Oh my goodness, what does that mean? The PEEP valve is something that you dial in on the end of the circuit. That's in the exhalation side. So it does not internally view PEEP. So you have to actually dial that in and set it, and then remember that when you're adding things like pressure support on there, as you add pressure support, the pressure support doesn't know that the PEEP is there, so you would have to add that on top of that. So say I was picking up a patient at an outline hospital, and that patient was on pressure support 5 there, right? So they're on a pressure support of 5 and their PEEP is 5, right? So when I go to put them on the LTV 1000, now remember, LTV 1000 has the external PEEP drive, not the 1200, not the NV, not the Revel. This is the one caveat to that. So I would look at what my PEEP is. I want to set my PEEP at 5, right? Because to match the one that they had there if the patient's doing well. And then I still want to have that same pressure support. So what I'm going to do is I'm not going to set a pressure support of 5 because the ventilator doesn't see that. I'm going to set it and add that on top of what the PEEP is. So now I'm going to set the pressure support at 10 to give me 5 centimeters of water pressure. So remember that pressure as you're going up, you're actually cutting, as you're going up on your PEEP, you're actually cutting into the pressure that's there. Otherwise, you'd be giving a pressure support of 0 and not knowing it. All right. So pay very close attention. If you have the LTV 1000, anytime you're dialing in a PEEP externally, pay very close attention to what your other settings are on there and what they're actually doing. All right. Moving on. All right, sensitivity. I don't know why you guys are not sensitive to my needs. If you take a look at the sensitivity on the LTV 1000, the 1200, and the Revel NV, it's dialed in based on liters per minute. So it's not 1 liter. If your sensitivity was set at 1 liter, it doesn't mean they have to pull back a liter. It means they have to pull back what would be a liter going through what that flow would feel like if it was a liter. I guess that's probably the easiest way to understand that. You want the patient to be able to trigger the ventilator, but you don't want to make it so sensitive that it auto cycles with every, blow of the wind. So you want to keep it. You want to adjust that so it's just allowing the patient when they create a negative flow going through the system, it's enough to trigger that ventilator to take a breath, but not one where it auto cycles. An auto cycle is the ventilator as the lungs close or semi-close. They create a negative deflection, which actually could cause the ventilator to trigger again. You could also have water in the circuit that was sloshing back and forth that can cause another trigger. So make sure the circuit is not dry, but there's no water sloshing, and then that it's not auto-cycling. But then if you are auto-cycling, just go up by 1 at a time until the patient's able to cycle on their own and it's not auto-cycling. Inspiratory time. That is the amount of time that the ventilator will be cycling inspiration. So a 1 second cycle time would just have the inspiration time being a total of 1 second. When you think about that would leave you with an exhalation time, right? You gotta have an exhalation time if you have an inspiration time. So as we have the increase in respiratory rate, we decrease the amount of time that the patient could have inspiratory time and expiratory time. So if you think on the lines of a respiratory rate of 10, you have 6 seconds because 10 goes into 60 6 times. So you have 6 seconds to have a inspiration and exhalation, and there'll be a small pause in there as well. But then if you think now we go up to a rate of 20, so 20 goes into 60 3 times. Now we have 3 second cycle time. So that means if we said that same 1 second I time, we have 1 second going in and 2 seconds going out. So now you can see where that can start to have a little bit of problem. We need to be able to exhale, and based on our disease process, our exhalation has to be longer or shorter than based on the disease process. If we have a restrictive lung injury, like what's going on with our COVID-19 patients or going into ARDS, they have very restrictive or rigid lungs that don't want to they're resisting expansion. So we're taking a longer time for inhalation. We don't have to worry much about exhalation time. I mean, we do, but not as much because those lungs want to slam shut. Now we have a COPD patient who has hyper expansive or hyper compliant lungs. They're able to get the air in just fine. It takes them a really long time to exhale, though. So we have to be very careful with that. If we are having inappropriate I times, we can significantly, we can cause significant problems with those patients, and we can actually kill them based on I time alone. So you have to be very comfortable and very competent with your I time settings. Make sure that you know the disease process. Remember, there's a lot of people that have confidence, but they don't have competence in mechanical ventilation. You want to make sure you have the competence, you have the understanding of what you're supposed to be doing, or you could really injure a patient. When we had transport teams bringing patients into the hospital, this is one of the number one things that we would see problems with is improper inspiratory time settings. That's not just age related. It's not just diagnosis for that that patient that one time. Not all COPDs are the same. Not all restrictive or ARDS patients are the same. You have to be very thoughtful on what you're doing. And if you need assistance, you need guidance in what you're doing, contact a respiratory therapist who knows what they're doing, or a pulmonologist that's overseeing the patient. If you're sending a patient to a hospital, that the receiving hospital should be able to help you set those I times correctly. So pay attention. So here's what I was just talking about on that. With a respiratory rate of 10, if you had the same I time for each one of these patients, that could cause significant problems as you get to a higher respiratory rate. That's why you wouldn't want to be at a higher respiratory rate without adjusting your IDE ratio, so your inspiratory to expiratory ratio. So because a rate of 10 goes into 60 seconds 6 times, then you have your cycle time being 6 seconds and your inspiratory time being 1 second. So you have 1 second going in and 5 seconds going out. And then you look at your, when you go to a rate of 20, like we were talking a second ago, 20 goes into 60 seconds 3 times. So you have a cycle time of 3 seconds. You have 1 second going in and 2 seconds going out. So this is still somewhat for a healthy patient an okay place to be, but most of us aren't actually breathing at a 1 to 2. We're breathing at a little bit longer than that, slightly longer. And then when you go to a rate of 30 and you have 1 second going in, so you need to think you have a total cycle time of 2 seconds. You have 1 second going in and 1 second going out. That's an inverse ratio. So you should only have extremely restrictive patients on an I time like that, or IDE ratio like that, and then they're going to have to be sedated and paralyzed as well, because that's extremely uncomfortable. So you could sit there and try to do a 1 second in, 1 second out breathing pattern. Make sure you're doing it above a bed or someplace soft, because you're going to pass out soon. And then 60 seconds, if you had, or 60 breaths a minute, if you had a cycle time of 1 second, because 60 goes into 61 time, and your I time was set at 1, you'd only have inspiration, you'd never have exhalation, and you'd kill the patient. So depending on the disease process, you can kill a patient on a rate of 30 easy, right? If you had an obstructive patient and you put them on a 1 second I time, they would never be able to exhale. So think about those things, and ask for help if you need it. All right, here's where we start getting a little bit fun and maybe more specifically related to these ventilators. You can have a 50 psi source going in to feed that patient oxygen and air, and it will blend it for you. You can use one of those little pigtails on the wall with a quick connect. And then you'll be getting, like if you had one with a smaller tank and you're transferring the patient, you can go real quick one to the next, and you'll have an alarm go off that says, low pressure source, and so then you can just press silence to that right after you move that patient over and you secured the source. Double check your vent for any other errors. So this is really good for patients with a high O2 demand. They're going to be pulling off a 50 psi source, which could be your oxygen source. They're going to be using all that, so it'd be beneficial. And it's going to save your battery life as well. So this is something that you might not think about unless you're using these ventilators on a regular basis. That turbine, people call it a compressor, and other ventilators, was actually a turbine on this one. It's spinning up, and spinning up, it uses a lot of battery life. If you're not plugged into the wall, that's going to suck away your battery pretty quick. If you're on especially the lower the FiO2, say you're at 21%, it's going to kill your battery really fast. Now, if you go over to a low pressure source, because maybe if you had a plug and you're able to, you had more electricity than gas source, you'd plug it in, and you can, and you needed a lower FiO2, it'd be great just to be plugged into the wall on a low pressure source. Low pressure source. Well, I can't even talk, right? So you're going to be running like maybe 1 or 2 liters per minute in there to bleed in for whatever the patient needs. You're gonna bleed in that much, but you have a much more controlled delivery of oxygen that way. Flow wise, right? And then you can let the compressor do the work. You do a regular O2 tubing in your Christmas tree or whatever your company supplier is calling it today, and a flow meter. That's how you do it. And make sure that you're pressing that little button on the side that says low O2 source. If you don't press that, it doesn't know that you're switching over to 50 psi, and it's gonna be pretty mad at you the whole time, and it's gonna start yelling at you. And if you don't know what that means, if you haven't read your manual, you are going to look like a fool with all those beeping and screaming. All right, oxygen source. This is where it gets a little bit more, a little. All right, oxygen sources. There's 2 different ways we can give oxygen to the patient through this ventilator. One would be through 50 psi, and the other would be through a low pressure source. I'm going to go opposite. The low pressure source is going to be a Christmas tree with an O2 tubing going to a flow meter, and you're going to blend that in, and you're going to blend it until you meet the desired need. If you look in the manual, there's actually a graph on there that'll show you what your FiO2 would be based on a minute ventilation that the patient is generating. If they're on a pressure support ventilation, their minute ventilation's all over the place. You're just going to have to kind of guess where they are most of the time. If they're more on not a controlled, but an assist control, and they're not breathing over, it's going to be a lot more accurate what your FiO2 would be. Make sure that you're pressing that low O2 source so the ventilator knows that you're using a low O2 source, and it doesn't keep beeping thinking that the PSI delivery is an error, right? Because if it thinks it's not getting 50 psi, it's going to start screaming at you, and you'll know right away. That 50 psi source is that quick connect that you have into the wall. Most of them are Ohios or Chemtrons that are the source on the wall. You could put one on a even the newer tanks that they have. The handle tanks that we call them. They have a 50 psi connect on the outside. You can screw one of those pigtails into that and then run a quick connect off of that tank, so you can plug the vent in really quickly. There's no lapse in O2 delivery. Those are really good for high O2 sources. If you want to do 100% on there, that's how you would deliver 100% is off your 50 psi source. Just remember that too, when you're at a high FiO2, and you're running that with the 50 psi going through there, you're going to save battery life. The compressor, actually on this one is a turbine. The turbine is going to generate flow, like compressed air for the ventilator, and then you bleed your FiO2 in normally. But if you're using a 50 psi source, you're giving it what it needs, and then you wouldn't have to blend that much in. If you're using the low pressure source and you have a cord for your ventilator that you're plugging it into the wall, and you're not too worried about electricity, you're going to be able to keep that running, and you can actually save some of your oxygen because you're delivering it at a slower, more controlled rate. So you have to think about what your needs are in that moment. Do I have more oxygen than I do electricity or battery life? If I have unlimited supply of oxygen, I'm going to do the 50 psi source. If I have a unlimited supply of electricity, I would do the low pressure source. Sounds good, right? All right, the rise time. This is something that a lot of people don't pay attention to on a lot of ventilators. If you don't have a lot of experience as a respiratory therapist, that might be something that you're not paying attention to. So rise time is going to occur in pressure control. If you look on, this is in your back modes. So if you're holding the select button down for a little bit, it'll allow you to go into the back modes. Then you can go to the rise time. But rise time, what that does is I call it the angle of attack, right? So you have your set inspiratory time. So say that little square on there is 1 second from the bottom left corner to the top right corner would be 1 second, or from the left line to the right line would be 1 second. The rise time is the angle of attack, so how quickly that flow reaches its peak. Now, if you really think about that, if it went in really fast, right, the rise time was set at 1 and it shot right up to the top and met that flow or met that pressure, then held the whole inspiratory time, you would have a much larger tidal volume than if it went from the beginning of inspiration and had an angle at a 9, which would bring it pretty much from the bottom left corner to the top right corner. So if you were to take that and then kind of shade that in or erase that, then you would see that you're really cutting in. You're almost making it half of the volume that it would be if you went from a rise time of 1 to a rise time of 9. Well, rise time of 1 would be a larger volume. So you really have to make sure that you're being careful with that number. That could really cut into your to your volume. And if you're transferring a patient, you have the settings the same, you could literally be cutting that patient's volume in half by not paying attention to the rise time. This is one of those numbers when people in the back screen, they set it when they're training somebody and they forget to put it back. And if they forget to put it back, that's when you get in trouble. So most of our patients, healthy patients, we're going to see somewhere around 6 for pediatric wise rise time, and then your obstructive patients, you'll see. It's just blah, motherfucker. Alrighty, rise time. This is the one of the ones that gets us in trouble if we're not paying attention to what we're doing. Rise time, you have to press your select button and it'll, hold it down for 3 seconds. That'll allow you to get into the back modes and turn the dial over till you get to rise time, and you'll see a 1 to 9 variable on there. 1 being the fastest and flow, and then 9 being the slowest flow. So let's talk about that real quick. If you look at your rise time, so that middle square that we have, the middle breath pattern, let's say that cycle time, or the inspiratory phase, is 1 second. Okay, there's a breath cycle, but the hard square or rectangle lines are the inspiratory phase. So the inspiratory phase, if you're at a 1 rise time, that would take that flow and it would rush it straight up to that peak pressure that we had set on there, or the pressure control setting, because this is something that's only used in pressure control. So we're forcing that the air goes in there really, really fast. Air O2 goes in there really fast and meets its pressure control setting, and then that flow continues and holds the airway open for that whole inspiratory phase. Now, here's the other side. If you had a rise time of 9, it's going to make that angle of attack go further to the right. So it'll make it more of like the bottom left part is the beginning of inspiratory, and it'll go all the way to the top right before it actually meets its peak pressure or its pressure control setting. So that could literally cut that volume in half. That's something we really need to pay close attention to, because if we're setting a patient up, say it's transport, we're going to set a patient up on the same settings that they're receiving at the sending facility. We go to put the pressure control the same, the PEEP the same, and the rise time is different. Say it was somebody was screwing around on the ventilator before, doing some training, and they left it there on 9. Now I think I think I should be getting very similar volumes, and I put the patient on there and they're not meeting the volume. Right? Well, that's probably the rise time. It's going too slow to meet the demand of the patient, or it's going too slow to meet the volume demand. So whenever we make a change on a ventilator, or set up a ventilator, we're looking at that. We should be looking at those numbers ahead of time to see where they are. And if we're adjusting them, we're looking at the volumes to see what it is. If I had the patient that was doing really well at an outlying facility, and I'm looking at their rise time, if I can mimic that would be great. And if not, then, well, if I didn't know what that numeric value was, I didn't understand their ventilator, I can adjust my rise time to get a similar volume. So just be very careful with what you're doing on there and make sure that you know what you're doing before you just start spinning dials. All right, here's a really cool thing that these ventilators have on here. If you look on, if you go to your vent screen and you scroll through and you hold that select button down and you go through until you hit O2 cylinder duration screen, you can enter the cylinder type and then enter the amount of liters in the tank that you have, or the PSI that's left. The tanks will normally have on the side, you have 690 liters in the E cylinder. The D cylinder is going to be 420. And then you scroll over to calculate, and it'll give you an estimated time that you should have on that tank. So that's now remember, we're always going to have a backup, and you always have a backup to your backup, right? In your mind, what are you going to do if this thing fails? But this gives you a good guideline of how long it should last. So hopefully you're going to use this not as like a, okay, I can get away with 1 tank. Hopefully you should use it as, hey, look, if something happened and the timeline got extended, 1 more tank, I can justify taking 1 more tank, even though it might make other people uncomfortable that I'm taking it. I don't want this patient to die while I'm transporting them. All right, so make sure you always have a backup tool. You're back up there and be safe. Okay, this is what I was referring to earlier when I talked about doing a low flow oxygen into the ventilator through that Christmas tree and an O2 tubing and a flow meter. So you can look on there and say, okay, what would my estimated FiO2 be? Say, let's scroll over and say my patient is on 12, is doing a minute ventilation of 12, and then follow that over. And if I wanted I'm trying to do it while I'm talking on a microphone. It's not as easy as you think it would be. And then scroll over so I want them at 15 liters. So what is that going to be? And it's going to be about 80%, right? So, and there's my kid smashing things around upstairs. So if you think this is easy, it's not. Solomon! I was recording a lecture! What? Dude, I told you I'm recording, and every time you fucking do that, I gotta start over.
I'm sorry. I shall be quiet.
No, you're not gonna be down here. You will not be down here while I'm doing this.
Okay, I'll grab the Xbox.
No, just go upstairs.
There's nothing else for me to do.
Yes, there is. Clean something else. Read your book. You have not read yet. And if mom comes home and you haven't read and you haven't done something, I'm going to be in trouble. So get your ass upstairs and read. I know you want to do stuff, but I got to finish this. One of us has a job to do.
I have a job.
This picks up everything.
I have a job.
Shut up! All right, after, I don't know, 5 attempts with my son coming down and interrupting, we can talk about low oxygen source and that graph that we talked about a little while ago. If you look on there, you can see, remember, we're doing this with our Christmas tree O2 tubing and a flow meter, and we're bleeding in the oxygen. If you look on the right-hand side, and you know how a graph works, right? I mean, you look at the right-hand side, and you'll see your minute ventilation on there. And then if you take your minute ventilation and you scroll over to where you would want, say I needed 80%, I'm scrolling over to 80%, and that would mean, you know, where is my flow going to be? And it's about, I don't know, it looks like 17 liters. That's what it looks like to me. I don't know. But that should be a generalized, this is right about 17 liters. It will give me an FiO2 of 80 with a minute ventilation of 12. I'm starting this over. All right. This is take 5 on this one because my son keeps interrupting me while I'm trying to do this. If you look on this is your low oxygen source. And remember, you press that button to switch it over to low oxygen. You put your Christmas tree on there. You have your O2 tubing hooked up to your flow meter, and you're running your flow. You're going to look at the minute ventilation that your patient is generating on the ventilator. If I'm looking at the minute ventilation and I'm saying, it looks like I'm going to say 10, and I want an FiO2 of 80, my old eyes are looking like that is going to be somewhere around 15 liters. That's what I would generate on that. So I put 15 liters on, should give me about 80% FiO2 for that patient. So it's a general, it's not perfect, but it's a graph that they put on there. So hopefully that'll help us out. All right. So altitude changes. Hopefully, we won't be doing too many transports with this, but if we do have to do transports, and you have altitude problems, you have a helicopter that is um, not pressurized, which most of them are not. This is something to think about. See, we live in Colorado, and altitude changes are pretty drastic over here. We can go up. If we're taking a patient in a helicopter, we can be up over 14,000 feet in no time. So 5,000 feet to 14,000 feet in 30 minutes. So that could be pretty significant volume changes. So the LTV and the 1200 and Revel they're not altitude compensated. There are ventilators out there that will say that they're altitude compensated if it's dialed in. All right. So if that's the case, then you would have to dial that in to the ventilator and pay very close attention to that. Remember, when you're coming back down in elevation, then you'd have to adjust it again. There's other ventilators out there like the Hamilton, the Eagle, Eagle Impact. A couple other transport ventilators that will have altitude compensation. That's great. Then you don't have to worry about it. But there's other things that you can do. If you put the patient in a pressure mode and watch their volumes, that should kind of protect you from a little bit of that. As we go up in altitude, remember our volumes expand. So when you're doing that, you're like if you're going from 0 to 17.7, I think it is, you're just about double your tidal volume. So pay very close attention to that. You don't want to cause any injury, especially if you have a patient who is in ARDS and you want their volumes to be low. You want to make sure that you're not overdoing it and causing any more problems. All right, here's something kind of cool. Hopefully, we won't need this too much. Again, kind of like the altitude compensation. If you think of your PO2 at different altitudes, if you're at sea level, your PO2 on ambient, PO2 should be 20.9 FiO2. That would be 159.21. Now that same room air, and then you go up to say 14,000 feet. Now you've got or 15,000 feet, 89.88. So that's a pretty significant drop in available oxygen that would allow to get over to your patient's blood vessels. So just be cognizant of that. Pay attention to what you're doing. Go up on FiO2 if you're going up in altitude, and to meet the patient's needs. All right, dad joke alert. This section might be alarming for you. Alarms are high pressure alarms. That's going to keep us from over pressurizing inside in the lungs. So to pop off, say if the patient's coughing really hard, and we don't want those peak pressures to be super high. If the patient's compliance is decreasing or their resistance is increasing, it's going to let us know that hey, genius, pay attention to your numbers on your vent and make sure it's set correctly. So we're going to set 5 to 10 centimeters of water pressure above the patient's peak airway pressure right now. That will hopefully give us an idea that things are changing. Maybe there's secretions in the airway that are increasing peak airway pressures due to resistance. So we can suction them out. Maybe they're biting the ET tube. We can put a bite block in. Maybe we left the suction catheter down the ET tube and it's causing a resistance problem. Or just the compliance and resistance is changing. Low PEEP, that usually means there's a leak. The ventilator is going to do its best to maintain a PEEP if it can. So pay real close attention when you see that low PEEP one. High respiratory rate, we're going to set it 10 to 15 breaths above a stable rate. That gives us an idea if the patient is is a little anxious, if they're uncomfortable, or if things are changing in their airway. Low pressure, again, low pressure is telling us that you probably have a leak somewhere. So you want to make sure you're looking up and down for it. And we always tell people you can either go from the ET tube to the circuit, or the circuit to the ET tube, and figure out where it's at. Just do it consistently. And be very systematic about what you're doing. Pay attention to everything. The more senses you're able to use on it, the better. So if you can feel it with your hand, then it's easier to locate. If you can hear it, it's usually one of those little caps that pops off, or your peep valve is leaking. It's got a crack in it. It's a loose connection somewhere. Remember, the FDA requires vents to have multiple alarms. They are annoying sometimes, right? Because one time you'll just connect the patient to do a procedure, and then you go to plug them back in. It's a beepity 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 beep. Well, it's going to keep beeping because it wants to have redundancy on there. It wants to make sure that you know that the patient is disconnected, and there's multiple different reasons why. So don't be mad at the ventilator companies. They're just doing what the government wants us to do. Ooh. All right. Our asthma patients, we want to do the best we can to not intubate our asthmatics. It ends up being very difficult to manage them on the vent. They are. I'm gonna start over. Our asthmatic patients are very difficult to manage on ventilators. Um, we have with asthmatics, we have a narrowing of the airway, which causes an increase in resistance, which causes a lot of air trapping as well. So the patient can't actually get the air out, and if we narrow the airway even more with an ET tube, it becomes problematic, right? So we try not to intubate them unless we have to. If we do, we want to shorten our I time to give them the ability to exhale as much as possible. Again, we're going to be giving our bronchodilators any treatments that we can that would manage them. And I'm not going to get into all that stuff right now. That's a whole nother lecture. We can do an expiratory hold on the LTV and Revel and NV. And that will give us an idea of how much intrinsic PEEP the patient actually has, so we can track whether we're actually doing good or bad for this patient. We can increase the PEEP as well to match their auto PEEP. And so why are we doing that? Why are we increasing the PEEP? What that does is it helps us, it helps the patient trigger the ventilator. So if we can match their intrinsic PEEP with PEEP, then we can allow that the patient to be able to flow trigger a little bit easier. Pressure trigger is going to be harder. Flow trigger is going to be a little bit easier. But unless you have something like NAVA, the patient's not going to be able to trigger the ventilator because it would have to suck back really, really hard to be able to trigger the vent. So matching their PEEP would allow that to occur. And then you can, as you do another expiratory hold, you're able to track where their PEEP is now and then go back and keep dialing down as they get better. All right, we're going to go light on the rest of these subjects, like traumatic chest injury. The patient's going to guard against inspiration because it's going to be painful with thoracic injuries. We want to make sure that we're managing them well with their pain. We're going to watch for pneumothorax. We always want to control their peak airway pressures, but remember, more importantly than peak airway pressures are going to be our plateau pressures. And we're going to just monitor the patient and do our best to assess them along the way as we get to the facility that we need to be at. We'll be able to do chest X-rays, CTs, MRIs, all that other good stuff. But we're mostly going to be treating the fuck. Alrighty, just heads up for the rest of the things that we're going over. I'm just going to go real light over those because they could be a whole lecture by themselves. Traumatic chest injuries, if you think about those, it could be from an MVA, it could be from a gunshot, knife, blunt force, any of that stuff. We want to make sure that we're have good pain management. We're assessing for pneumothorax, hemothorax. And then remember that the patient's going to guard against inspiration if they have a lot of pain. So they're going to have a lot. They're going to forcefully do a higher respiratory rate with a lower volume, so to decrease the pain or lower pressure. So make sure you're controlling your peak airway pressures, but more importantly, your plateau pressures, and then keep assessing them over and over until you get there. Then get a CT, MRI, X-ray, everything that's really, really expensive. All right, our lovely COPD patients, remember they have trouble exhaling, very similar to our asthmatics. So what are we going to do? We're going to shorten their eye time. We're going to monitor for air trapping, doing an inspiratory hold. Remember, inspiratory hold allows us to get a plateau, which is wrong. All righty, our COPD patients, I think I say all right a lot. Do I say all right a lot? Okie dokie. COPD patients, chronic obstructive pulmonary disease. Well, we know about them as they can't exhale. They're kind of similar to an asthmatic. We are going to do an expiratory hold to find out what their intrinsic PEEP is. We may need to shorten their eye time even lower than what we did before so we can blow off more CO2. They may need some bronchodilators. Almost just said all wrong stuff, but they may need their bronchodilators to help open up the airways to allow them to exhale a little bit better. And know what your correct target for your blood gas would be on this one. Remember, if they have a bicarb of 35, is their CO2 going to be 35 to 45? Well, no, it's not, right? So then you want to target what it is that their pH normally would be. Hopefully they have it in a chart. Hopefully the family member knows, or you can kind of guess or calculate off of your bicarb where they would be. Avoid intubation if possible. Try BiPAP if you can. Now, in these, like where we are right now with a viral infection being very popular, BiPAP might not be a great idea at all, because now you're going to particulate, especially if you're in an ambulance, you're going to particulate that all over the ambulance. And yeah, even with a really good mask, you're probably going to be breathing some of it in. So be very careful. They're coming out with a very high flow. If you have a nasal mask, they're going to be exhaling through their mouth. If you have a full size mask, it should decrease the amount of particulation. But you have a whisper valve on there that's going to blow it all over the ambulance and the airplane or wherever it is. So just be very careful about what you're doing. Make sure you're following your guidelines from your hospital. All right. Oh, shit. So do yourself a favor. There's quite a few videos on implementation of the LTV 1000, 1200, Revel, and NV online. So you can watch some videos on those. Hopefully this is just a good guideline of what you should be doing, and a basic understanding for our newer practitioners. Um, it's a great ventilator. It's very versatile. It does a lot of things. You just got to know the little tricks and caveats to it, and you'll be fine. If you have any questions at all, speak to one of your, and it sounds funny, but your more advanced therapist. And when I say that, we're not supposed to say, older, but when we think about it, these are the ones that they used when they were, years back. So, ask them, see what advice they have for you, and let's. Oh. So we're almost done here. Go ahead and if you have time, it's really beneficial to look through your manual, read it so you know the capabilities of that ventilator, the weaknesses and strengths of it. Every one of them has weakness. Every one of them has strengths. But if you're the one with a weakness, if you don't know which ventilator does what, there's a couple articles on there for you. And then hop on YouTube. Hop on the webs. The owner's manual websites, right? The fuck me, holy shit. All right, we're almost done. Do yourself a favor, open up that Pulmonetics manual, or Viasis, or whatever age related ventilator you have. Go through the manual, know what the strengths and the weaknesses are. Every ventilator has a strength and everyone has a weakness. But the practitioner that doesn't know what those are, they are the weakness. So know what you're supposed to be doing, how to do it, and hop on their website. There's some videos on there on how to do things. It's only going to make you better. This crisis situation right now, we want to make sure we're still providing excellent care for our patients, so we can get them off the ventilator and put somebody else on there that might need it. All right. Well, I'll talk to you guys soon. Call me with any questions. You can email me at justinmizuraka@yahoo.com. That's justinmizuraka@yahoo.com. I know I need a new email address. It's old, but send me a message if you need, and if you see anything that needs to be corrected or adjusted, let me know and I'll fix it. All right. Take care. All right. Assist control ventilation. This is a mode that is used by respiratory therapists and medical doctors around the world. And what that is designed to do is to have a set respiratory rate with a set volume. The example we're using is a respiratory rate of 10 and a tidal volume of 500, which would be the appropriate volume for that patient, or else we're not going to give it. So remember, 6 to 8 mLs per kilo for a ideal body weight. And then we can go lower on that volume, 4 to 6 mLs per kilo on a restrictive patient like ARDS, something that you might see with the COVID-19 illness. All right. The patient's able to trigger a breath throughout this whole course, but after they might get a breath, one of their 10 breaths. Remember, 10 breaths is going to be, if you divide 10 into 1 minute, which would be 60 seconds, it'll give you a 6-second cycle time. So that would be where I restart this. Assist control ventilation. This is used quite frequently around the world by respiratory therapists and doctors, pulmonologists, nurse practitioners, everyone in between. The idea of this ventilation mode is to give a respiratory rate, a volume, set an I-time sensitivity, PEEP, FiO2. The rate, we're going to use, this is what we're setting right now in our minds, just so we can understand the process. Setting a respiratory rate of 10. A respiratory rate of 10 goes into 60 seconds 6 times. So every 6 seconds, we should be getting a breath. There's some time in between there. So if the patient wants to breathe more, what are they going to get? Well, they're not going to get what they generate. They're going to get that 500 mLs that we gave them. So if we said a respiratory rate of 10 and a tidal volume of 500, every single time that the ventilator cycles, it's going to be a volume of 500 mLs. Whether it was what the ventilator was cycled to do or what the patient is triggers it to do, is always going to be a tidal volume of 500. So one of the problems that we may come into is as the patient increases their respiratory rate, we could start to impede on the expiratory time, because if you had a set inspiratory time, the patient's taking a breath, there's only 6 seconds to cycle for that ventilator to cycle again. So then as the patient increases their respiratory rate, it could really start to mess up the I to E ratio on the ventilator. There you go. Oh, I'm having so much fun. I I can't I sit there and I feel like I'm gonna just fucking scream. Oh, it's terrible. But yeah, I just finished building this lecture for emergency management with the LTVs and Revel. So, and I did voiceover on it. So hopefully, I'm saving that. I'm trying to do it to the announcements so everybody can have it, but I don't know. It's going really freaking slow. Yeah, like I'm trying to like actually upload it, and it won't. No, no, it's just a lecture. You know the lecture thing. Yeah. No, well, it was just to the main email. You know the main announcements. So I don't know if that's gonna be possible. I might have to do a link to a YouTube or something. You know. Oh well, you know what? Can I just send it to you up to Peepity? Oh, oh shit. Why? That's crazy, huh? I there it goes. Uh, Here is a vent lecture about what are those called? LTVs and what did I say? The other one was the Revel. I'm losing my fucking mind. My son is like, no, no, but it's for, it's the class that I taught for, um, all the transport teams. It's what's in the cash system. Uh, Emergency preparedness. Can't prepare. Uh, Not writing that word. If you can't spell it, then don't put it in there, right? Yeah. Uh, Voiceovers on each slide. Boom. All right, submitted. Now I can go back upstairs. My son is fucking pissing me off. Every time I'm in a meeting, he's like, I'm like, I have to be on mute. I know. I've already decided to. So, I haven't talked to you about this yet, but university wants.
Actually, they might, because all they can do is sit on my bed. I think I'm losing my mind. It's actually inside of my lungs. Okay, no more restful, no more restful. Listen, listen, can't more restful, listen, restful. I think I'm losing my mind. But try to stay inside the lungs. I think I want me to stay. I think I'm losing. Just trying to stay inside the line. You don't want me to stay.
All right, so let's talk about some goals related to mechanical ventilation. If this is something that you're not very comfortable with yet, you want to know that managing a patient on a mechanical ventilation is the desire is to keep them as comfortable as you possibly can. So getting them to be able to trigger the ventilator in a way that's sensitive enough for them so they're not anxious. If they're anxious, they're going to need sedation, they're going to need paralytics, and we don't want that because if we increase their sedation and give them paralytics, it's going to increase the length of stay in the hospital. Right now, we need those ventilators, and we want to make sure that the patient gets out of there as soon as possible so they don't have a nosocomial infection that causes them to get even more sick. So let's make them comfortable and let's keep them safe. Think about our VAP programs, and we'll talk about that maybe in another lecture about decreasing ventilator-associated pneumonia. But this one we're going to hit on a little bit and move on to the next slide. All right, we want to make sure that we're beginning to treat our patients like they're in the ICU right away. So having different policies and procedures outside of the hospital might not be the greatest idea. Sometimes they have to be that way, but if the more we can get them on the level of what the ICU would be treating them would be great. That's why sitting with a well-versed practitioner and learning from them will get you to be a better therapist yourself. We want to attempt to keep the patient alive and doing well, and get them in better shape than they were when we picked them up. Say we're out transferring a patient from one hospital to the next. One, we're going to make sure that we're protecting ourselves as much as we can, and then also making sure that we're doing those things that would the receiving hospital is doing. Not the sending hospital, but the receiving hospital. The sending hospital might be sending them because they don't have enough equipment, or they need to escalate in care, but the receiving hospital is the one that should be dictating the settings on the ventilator, the management of the patient. And we want to start to decrease the amount of days the patient will spend on the ventilator, and the amount of days they'll spend in the hospital, by giving good quality care, making sure the patient is as safe as possible, and not causing any more infections than they might already have. So this is where we're going to do ourselves a big favor. We want to make sure that we're doing our vent check ahead of time. We're checking our circuit for leaks. We're make sure everything is functioning the way it should be before we actually put the patient on. There's been too many times I've gone to check to see if I can help a transport team assess their ventilator because they're not understanding what's going on, and I always think it's the patient that's causing the problem. But if there's a leak in the system when you are turning it on, you will always continue to think it's the patient that has the problem and not necessarily the ventilator that has the problem. So do yourself a favor, check the equipment, check for a leak by doing the leak check. You check to see if all the lights light up and the noises that the ventilators are supposed to make are doing what they're supposed to. If you do have a leak, make sure you start from one side of the circuit and check for that leak that way. A lot of times on these ventilators, the connections are the points that they have a leak. So we backspin those, the flow sensor and the pressure sensor. If you backspin those before you put them on, it has this positive pressure against keeping that circuit tight, and you want those things to be tight on there because you're going to flip that ventilator back and forth when you're moving a patient either outside the hospital or going to CT, MRI, when X-ray comes in. Whatever you're doing, you want to make sure that they stay nice and snug. If it senses a leak, you'll see immediately a massive amount of tidal volume going through there. It's not actually receiving that tidal volume. The flow sensor is just increasing flow to the system. Remember, flow times I time equals tidal volume. So with that flow going by to make up the difference, that leak, it'll make that number look huge. Most common places that you're going to see a leak are those connectors, and then also the PEEP valve is easy to crack on those things. So make sure that thing is attached and it's not cracked. And then anytime you're doing a check on a circuit to make sure it is working, you want to make sure you're doing it with everything that you would have in line. If you're using a viral filter or HME, or a humidifier, you want to test the system with that in place. All right, next slide. All right, well, I already mentioned that other stuff about making sure all those things are in line when you're testing the system, but also you should make sure the ventilator is plugged into a power source when you're doing that. You're just going to get the best results that way. And then also, if you're going to be transferring back and forth, don't trust that internal battery, the length of it. We don't know how long ago that had been swapped out. You're going to have an external battery hooked onto that, just to make sure you're not going to get yourself in trouble. Once you hit that internal battery as the last bit of electronics that you have, you better make sure that thing's plugged in and you find a power source right away. Make sure your bag is ready for you. All right, for those of you who are not well versed in mechanical ventilation modes, a little bit of history. Controlled ventilation, this is what we used to use with anesthesiologists, docs a long time ago, back before we had a good understanding or the good capabilities of ventilators to manage a patient, and allow them to do the most of the work. Controlled ventilation, and we call it like the God mode. The patient doesn't have a choice of what they're doing. They get a rate that's set, a volume that's set, PEEP, FiO2, and that's what they get. And you get what you get, and you don't throw a fit. There's no sensitivity. The patient can't trigger the vent, and they get everything that anesthesiologist is giving them. If they want more, the anesthesiologist is going to realize they're waking up, and they're going to sedate and paralyze more, so then they can control that ventilation. Again, look at it like the God mode. All right, so it's this control mode of ventilation. It's used by respiratory therapists and MDs in the hospital all the time. It's a very common, very frequent mode that we use. The patient can trigger a breath, but only gets the volume that the provider sets for them. So say I'm setting a 500 ml tidal volume, which would only be the appropriate volume, which would be 6 to 8 mLs per kilo for most patients. A restricted patient, a little bit smaller tidal volume, but you want to make sure you're using your ideal body weight for that patient as well. So that the patient can take a breath, more breaths if they want to, but what they're always going to get is that 500 ml tidal volume that was set. So everything else is set for that patient, but they can increase their minute ventilation. Remember, minute ventilation is tidal volume times respiratory rate. So if they're taking more breaths of that tidal volume, their minute ventilation should go up accordingly. But the other thing, so I can hear my kids talking in the background. The other thing is they can never go below that respiratory rate that's set, and or that tidal volume. Most cases. All right, this would be the second recording of what is assist control. My kids interrupted me while I was talking. So assist control ventilation is used by most respiratory therapists and MDs, whoever's setting up the vent. That mode of ventilation is designed to get the patient a steady minute ventilation. Remember, minute ventilation is the tidal volume times the respiratory rate. The patient can trigger a breath, but every time they go to cycle a breath, they're going to get that same tidal volume that was set. So say I have a 500 ml tidal volume, which would be, I'm only going to set one that's appropriate to that patient's ideal body weight times 6 to 8 mLs per kilo, or in a restricted patient down to 4 to 6 mLs per kilo. So that the patient's getting that breath, and every time they take a breath, they get the same 500 mLs. They can breathe as many times more than they want, over what was set, but they're always going to get that 500 mLs. But they will continue to get that same volume, the same I time, same sensitivity. So when you think of the I time problem, as the patient starts to breathe over that much more, then we start to impede or cause problems with their I time, because that I time is going to take up a set amount of time in that cycle, well, for that cycle, so that we're going to start narrowing the amount of time that the patient can exhale. So that's something we have to be careful with. Assist control ventilation. This is a mode that is used by respiratory therapists and medical doctors around the world. And what that is designed to do is to have a set respiratory rate with a set volume. The example we're using is a respiratory rate of 10 and a tidal volume of 500, which would be the appropriate volume for that patient, or else we're not going to give it. So remember, 6 to 8 mLs per kilo for a ideal body weight. And then we can go lower on that volume, 4 to 6 mLs per kilo on a restrictive patient like ARDS, something that you might see with the COVID-19 illness. All right, the patient's able to trigger a breath throughout this whole course, but after they might get a breath, one of their 10 breaths. Remember, 10 breaths is going to be, if you divide 10 into 1 minute, which would be 60 seconds, it'll give you a 6-second cycle time. So that would be where I assist control ventilation. This is used quite frequently around the world by respiratory therapists and doctors, pulmonologists, nurse practitioners, everyone in between. The idea of this ventilation mode is to give a respiratory rate, a volume, set an I time, sensitivity, PEEP, FiO2. The rate, we're going to use, this is what we're setting right now in our minds, just so we can understand the process. Setting a respiratory rate of 10. A respiratory rate of 10 goes into 60 seconds 6 times. So every 6 seconds, we should be getting a breath. There's some time in between there. So if the patient wants to breathe more, what are they going to get? Well, they're not going to get what they generate. They're going to get that 500 mLs that we gave them. So if we said a respiratory rate of 10 and a tidal volume of 500, every single time that the ventilator cycles, it's going to be a volume of 500 mLs. Whether it was what the ventilator was cycled to do or what the patient is triggers it to do is always going to be a tidal volume of 500. So one of the problems that we may come into is as the patient increases their respiratory rate, we could start to impede on the expiratory time, because if you had a set inspiratory time, the patient's taking a breath, there's only 6 seconds to cycle for that ventilator to cycle again. So then as the patient increases their respiratory rate, it could really start to mess up the I to E ratio on the ventilator. There you go. Alrighty. Intermittent mandatory ventilation. What this mode does is gives a patient a set amount of breaths. So same thing like control, or very similar to control, but there's going to be a little variable I'm going to hit on in a second. So let's just use this example. We're going to use this example through the rest of the lectures. The ventilator we're going to say is set at a rate of 10, and the volume is set at 500 mLs. That rate set at 10 will allow 10 breaths a minute at 500 mLs a time. Now the patient in this mode can breathe over the ventilator if they choose to. The difference is they will not get assistance on that breath at all. It's not going to generate 500 mLs. It's going to generate only what they can generate. Now think about the breathing tube causing a increased resistance. You have a piece of polyvinyl chloride inside the airway, which will decrease the foramen size. As it decreases the foramen size, resistance goes up. So it becomes more difficult for that patient to take a breath because the airway is narrowed, right? So they're trying to take a breath, but they really can't create the same breath that they'd be able to breathe if they didn't have that breathing tube in. And there's no assistance that allows them to take a breath. Well, here's the big dangerous caveat to this mode of ventilation. That patient is, when they're cycling their breath, they can they'll get that whatever volume they can generate. So say they generate 200 mLs, now the ventilator cycles time cycle, and it's giving 500 mLs. So that 200 now goes to 700. So we don't want that to happen. So that's why we're not using IMV. But it's good to know where we were so we can know where we're going. All right. On to the next one. Alrighty, here we go. SIMV, synchronized intermittent mandatory ventilation. Now, here's the interesting part about this mode. What that does is it synchronizes the breaths of the patient's breath along with the mechanical breath. And so it sounds a little confusing when you first start talking about it. But remember, IMV, we were talking about that the patient could take a breath and then the ventilator does not care. It's time cycled. So every 6 seconds, it's going to deliver a breath. Because we said it was a rate of 10, so 10 goes into 60 6 times. Every 6 seconds we cycle a breath. So if the patient decided to start taking a breath at 5.5 seconds, the ventilator doesn't care and it would step on their breath. Well, synchronized intermittent mandatory ventilation synchronizes the ventilator. So if it sees you or feels you or senses you taking a breath, that the ventilator will not add its breath on top of your breath. So that's a really nice safety feature, right? It protects the airways and decreases the likelihood that ventilator is going to step on the patient's breath and add too large of a volume to their breathing pattern. All right, synchronized intermittent mandatory ventilation. Holy moly, that's a mouthful, right? So SIMV is a mode of ventilation. We're going to allow the patient to breathe as many times as they want on their own. They can generate whatever they want to generate on their extra breaths, kind of like IMV. But the difference with this, we're going to give them pressure support. So what pressure support is it's a pressure that supports the patient. That's pretty novel, isn't it? That pressure, as we increase that numeric value, so it'd be say like 5 centimeters water pressure to 10 centimeters water pressure, we're giving them a increased pressure, which can generate a larger volume. So they can take a bigger breath on their own breaths. So they'll have their set breaths. So I had to say I had a rate of 10 on there. They're breathing 10 times, and say the volume was 500 mLs per breath that we have set for them. If for 10 breaths, they're getting that 500 mLs. In between those breaths, the ventilator will allow them to take those breaths without without being impeded on, right? So then it's not going to cycle another breath while that patient is in their breath phase. So that keeps the patient from stacking breaths. So if they were in their own breath pattern and they were generating, say, 300 mLs, we wouldn't want the ventilator to step on that breath and give them another 500 on top of that. We want it to wait, and depending on the algorithm of that specific ventilator, the patient will be able to finish their breath, or almost completely finish their breath before the ventilator cycles another breath. Oh, pressure support. Oh, how we love thee, right? The pressure support we just talked about is, interesting enough, it could be a mode in itself, or it could be an adjunct to another mode. So you can have a pressure control breath along with pressure support, or you can have a volume control breath along with pressure support, or you can have its own mode where you're just doing pressure support, PEEP, and FiO2 are the only things you're really setting on it. Well, a couple caveats to that. But that would be the majority of the things that you're setting on there, and the patient actually breathes on their own, their normal breathing pattern, and they get the volumes that they're hopefully that they want. They're taking their breath, and they're getting some assistance to overcome the resistance of the ED tube, or allow us to give a larger breath for that patient to meet their pH balance, or their CO2 removal. All right, next one. All right, so again, pressure support can be its own mode, and it can be an adjunct to a mode. So one of the things to think about now, hopefully the majority of these things you won't see any of them, but your LTV 1000 has an external PEEP drive. Oh my goodness, what does that mean? The PEEP valve is something that you dial in on the end of the circuit. That's in the exhalation side. So it does not internally view PEEP. So you have to actually dial that in and set it, and then remember that when you're adding things like pressure support on there, as you add pressure support, the pressure support doesn't know that the PEEP is there, so you would have to add that on top of that. So say I wanted to, say I was picking up a patient at an outline hospital, and that patient was on pressure support 5 there, right? So they're on a pressure support of 5 and their PEEP is 5, right? So when I go to put them on the LTV 1000, now remember, LTV 1000 has the external PEEP drive, not the 1200, not the NV, not the Revel. This is the one caveat to that. So I would look at what my PEEP is. I want to set my PEEP at 5, right? Because to match the one that they had there if the patient's doing well. And then I still want to have that same pressure support. So what I'm going to do is I'm not going to set a pressure support of 5 because the ventilator doesn't see that. I'm going to set it and add that on top of what the PEEP is. So now I'm going to set the pressure support at 10 to give me 5 centimeters of water pressure. So remember that pressure as you're going up, you're actually cutting, as you're going up on your PEEP, you're actually cutting into the pressure that's there. Otherwise, you'd be giving a pressure support of 0 and not knowing it. All right. So pay very close attention. If you have the LTV 1000, anytime you're dialing in a PEEP externally, pay very close attention to what your other settings are on there and what they're actually doing. All right. Moving on. All right, sensitivity. I don't know why you guys are not sensitive to my needs. If you take a look at the sensitivity on the LTV 1000, the 1200, and the Revel NV, it's dialed in based on liters per minute. So it's not 1 liter. If your sensitivity was set at 1 liter, it doesn't mean they have to pull back a liter. It means they have to pull back what would be a liter going through what that flow would feel like if it was a liter. I guess that's probably the easiest way to understand that. You want the patient to be able to trigger the ventilator, but you don't want to make it so sensitive that it auto cycles with every, blow of the wind. So you want to keep it. You want to adjust that so it's just allowing the patient when they create a negative flow going through the system, it's enough to trigger that ventilator to take a breath, but not one where it auto cycles. An auto cycle is the ventilator as the lungs, close or semi-close, they create a negative deflection, which actually could cause the ventilator to trigger again. You could also have water in the circuit that was sloshing back and forth that can cause another trigger. So make sure the circuit is not dry, but there's no water sloshing, and then that it's not auto cycling. But then if you are auto cycling, just go up by one at a time until the patient is able to cycle on their own and it's not auto cycling. Inspiratory time. That is the amount of time that the ventilator will be cycling inspiration. So a 1 second cycle time would just have the inspiration time being a total of 1 second. When you think about that, that would leave you with an exhalation time, right? You gotta have an exhalation time if you have an inspiration time. So as we have the increase in respiratory rate, we decrease the amount of time that the patient could have inspiratory time and expiratory time. So if you think on the lines of a respiratory rate of 10, you have 6 seconds because 10 goes into 60 6 times. So you have 6 seconds to have a inspiration and exhalation, and there'll be a small pause in there as well. But then if you think now we go up to a rate of 20, so 20 goes into 63 times. Now we have 3 second cycle time. So that means if we said that same 1 second I time, we have 1 second going in and 2 seconds going out. So now you can see where that can start to have a little bit of problem. We need to be able to exhale, and based on our disease process, our exhalation has to be longer or shorter than based on the disease process. If we have a restrictive lung injury, like what's going on with our COVID-19 patients or going into ARDS, they have very restrictive or rigid lungs that don't want to, they're resisting expansion. So we're taking a longer time for inhalation. We don't have to worry much about exhalation time. I mean, we do, but not as much because those lungs want to slam shut. Now we have a COPD patient who has hyper expansive or hyper compliant lungs. They're able to get the air in just fine. It takes them a really long time to exhale though. So we have to be very careful with that. If we are having inappropriate I times, we can significantly, we can cause significant problems with those patients, and we can actually kill them based on I time alone. So you have to be very comfortable and very competent with your I time settings. Make sure that you know the disease process. Remember, there's a lot of people that have confidence, but they don't have competence in mechanical ventilation. You want to make sure you have the competence, you have the understanding of what you're supposed to be doing, or you could really injure a patient. When we had transport teams bringing patients into the hospital, this is one of the #1 things that we would see problems with is improper inspiratory time settings. That's not just age related. It's not just diagnosis for that, that patient that one time. And not all COPDs are the same. Not all restrictive or ARDS patients are the same. You have to be very thoughtful on what you're doing. And if you need assistance, you need guidance in what you're doing, contact a respiratory therapist who knows what they're doing, or a pulmonologist that's overseeing the patient. If you're sending a patient to a hospital, that the receiving hospital should be able to help you set those I times correctly. So pay attention. So here's what I was just talking about on that. With a respiratory rate of 10, if you had the same I time for each one of these patients, that could cause significant problems as you get to a higher respiratory rate. That's why you wouldn't want to be at a higher respiratory rate without adjusting your I to E ratio, so your inspiratory to expiratory ratio. So because a rate of 10 goes into 60 seconds 6 times, then you have your cycle time being 6 seconds and your inspiratory time being 1 second. So you have 1 second going in and 5 seconds going out. And then you look at your when you go to a rate of 20, like we were talking a second ago, 20 goes into 60 seconds 3 times. So you have a cycle time of 3 seconds. You have 1 second going in and 2 seconds going out. So this is still somewhat for a healthy patient an okay place to be, but most of us aren't actually breathing at a 1 to 2. We're breathing at a little bit longer than that, slightly longer. And then when you go to a rate of 30 and you have 1 second going in and now so you need to think you have a total cycle time of 2 seconds. You have 1 second going in and 1 second going out. That's an inverse ratio. So you should only have extremely restrictive patients on an I time like that, or IDE ratio like that. And then they're going to have to be sedated and paralyzed as well because that's extremely uncomfortable. So you could sit there and try to do a 1 second in, 1 second out breathing pattern. Make sure you're doing it above a bed or someplace soft because you're going to pass out soon. And then 60 seconds, if you had, or 60 breaths a minute, if you had a cycle time of 1 second, because 60 goes into 61 time, and your I time was set at 1, you'd only have inspiration, you'd never have exhalation, and you'd kill the patient. So depending on the disease process, you can kill a patient on a rate of 30 easy, right? If you had an obstructive patient and you put them on a 1 second I time, they would never be able to exhale. So think about those things and ask for help if you need it. All right, oxygen sources. There's 2 different ways we can give oxygen to the patient through this ventilator. One would be through 50 psi, and the other would be through a low pressure source. I'm going to go opposite. The low pressure source is going to be a Christmas tree with an O2 tubing going to a flow meter, and you're going to blend that in, and you're going to blend it till you meet the desired need. If you look in the manual, there's actually a graph on there that'll show you what your FiO2 would be based on a minute ventilation that the patient is generating. If they're on a pressure support ventilation, their minute ventilation's all over the place. You're just going to have to kind of guess where they are most of the time. If they're more on not a controlled, but an assist control, and they're not breathing over, it's going to be a lot more accurate what your FiO2 would be. Make sure that you're pressing that low O2 source so the ventilator knows that you're using a low O2 source, and it doesn't keep beeping thinking that the PSI delivery is an error, right? Because if it thinks it's not getting 50 psi, it's going to start screaming at you, and you'll know right away. That 50 psi source is that quick connect that you have into the wall. Most of them are Ohios or Camtrons that are the source on the wall. You can put one on a even the newer tanks that they have. The handle tanks that we call them. They have a 50 psi connect on the outside. You can screw one of those pigtails into that and then run a quick connect off of that tank so you can plug the vent in really quickly. There's no lapse in O2 delivery. Those are really good for high O2 sources. If you want to do 100% on there, that's how you would deliver 100% is off your 50 psi source. Just remember that too, when you're at a high FiO2, and you're running that with the 50 psi going through there, you're going to save battery life. The compressor, actually on this one is a turbine. The turbine is going to generate flow, like compressed air for the ventilator, and then you bleed your FiO2 in normally. But if you're using a 50 psi source, you're giving it what it needs, and then you wouldn't have to blend that much in. If you're using the low pressure source and you have a cord for your ventilator that you're plugging it into the wall, and you're not too worried about electricity, you're going to be able to keep that running, and you can actually save some of your oxygen because you're delivering at a slower, more controlled rate. So you have to think about what your needs are in that moment. Do I have more oxygen than I do electricity or battery life? If I have unlimited supply of oxygen, I'm going to do the 50 psi source. If I have a unlimited supply of electricity, I would do the low pressure source. Sounds good, right? Alrighty, rise time. This is the one of the ones that gets us in trouble if we're not paying attention to what we're doing. Rise time, you have to press your select button and hold it down for 3 seconds. That'll allow you to get into the back modes and turn the dial over till you get to rise time, and you'll see a 1 to 9 variable on there. 1 being the fastest and flow, and then 9 being the slowest flow. So let's talk about that real quick. If you look at your rise time, so that middle square that we have, the middle breath pattern, let's say that cycle time, or the inspiratory phase is 1 second. Okay, there's a breath cycle, but the hard square or rectangle lines are the inspiratory phase. So the inspiratory phase, if you're at a 1 rise time, that would take that flow and it would rush it straight up to that peak pressure that we had set on there, or the pressure control setting, because this is something that's only used in pressure control. So we're forcing that the air goes in there really, really fast. Air O2 goes in there really fast and meets its pressure control setting, and then that flow continues and holds the airway open for that whole inspiratory phase. Now, here's the other side. If you had a rise time of 9, it's going to make that angle of attack go further to the right. So it'll make it more of like the bottom left part is the beginning of inspiratory, and it'll go all the way to the top right before it actually meets its peak pressure or its pressure control setting. So that could literally cut that volume in half. That's something we really need to pay close attention to, because if we're setting a patient up, say it's transport, we're going to set a patient up on the same settings that they're receiving at the sending facility. We go to put the pressure control the same, the PEEP the same, and the rise time is different. Say it was somebody was screwing around on the ventilator before, doing some training, and they left it there on 9. Now I think I think I should be getting very similar volumes, and I put the patient on there and they're not meeting the volume. Right? Well, that's probably the rise time. It's going too slow to meet the demand of the patient, or it's going too slow to meet the volume demand. So whenever we make a change on a ventilator, or set up a ventilator, we're looking at that. We should be looking at those numbers ahead of time to see where they are. And if we're adjusting them, we're looking at the volumes to see what it is. If I had a patient that was doing really well at an outlying facility, and I'm looking at the rise time, if I can mimic that, that would be great. And if not, then, well, if I didn't know what that numeric value was, I didn't understand their ventilator, I can adjust my rise time to get a similar volume. So just be very careful with what you're doing on there and make sure that you know what you're doing before you just start spinning dials. All right, here's a really cool thing that these ventilators have on here. If you look on, if you go to your vent screen and you scroll through and you hold that select button down and you go through until you hit O2 cylinder duration screen, you can enter the cylinder type and then enter the amount of liters in the tank that you have or the PSI that's left. Um, the tanks will normally have on the side, you have 690 liters in the E cylinder. The D cylinder is going to be 420. And then you scroll over to calculate, and it'll give you an estimated time that you should have on that tank. So that's now remember, we're always going to have a backup, and you always have a backup to your backup, right? In your mind, what are you going to do if this thing fails? But this gives you a good guideline of how long it should last. So hopefully you're going to use this not as like okay, I can get away with one tank. Hopefully you should use it as, hey, look, if something happened and the timeline got extended, one more tank, I can justify taking one more tank, even though it might make other people uncomfortable that I'm taking it. I don't want this patient to die while I'm transporting them. All right, so make sure you always have a backup tool. You're back up there and be safe. Okay, this is what I was referring to earlier when I talked about doing a low flow oxygen into the ventilator through that Christmas tree and an O2 tubing and a flow meter. So you can look on there and say, okay, what would my estimated FiO2 be? Say, let's scroll over and say my patient is on 12 is doing a minute ventilation of 12, and then follow that over. And if I wanted I'm trying to do it while I'm talking on a microphone. It's not as easy as you think it would be. And then scroll over so I want them at 15 liters. So what is that going to be? And it's going to be about 80%, right? So and there's my kids smashing things around upstairs. So if you think this is easy, it's not.
No, my food.
All right. This is take 5 on this one because my son keeps interrupting me while I'm trying to do this. If you look on this is your low oxygen source. And remember, you press that button to switch it over to low oxygen. You put your Christmas tree on there. You have your O2 tubing hooked up to your flow meter, and you're running your flow. You're going to look at the minute ventilation that your patient is generating on the ventilator. If I'm looking at the minute ventilation and I'm saying it looks like I'm going to say 10, and I want an FiO2 of 80, my old eyes are looking like that is going to be somewhere around 15 liters. That's what I would generate on that. So do I put 15 liters on? Should give me about 80% FiO2 for that patient. So it's a general. It's not perfect, but it's a graph that they put on there. So hopefully that'll help us out. All right. So altitude changes. Hopefully, um, we won't be doing too many transports with us, but if we do have to do transports, and you have altitude problems, you have a helicopter that is um, not pressurized, which most of them are not. This is something to think about. See, we live in Colorado, and altitude changes are pretty drastic over here. We can go up. if we're taking a patient in a helicopter, we can be up over 14,000 feet in no time. So, 5,000 feet to 14,000 feet in 30 minutes. So that could be pretty significant volume changes. So the LTV and the 1200 and Revel they're not altitude compensated. There are ventilators out there that will say that they're altitude compensated if it's dialed in. All right. So if that's the case, then you would have to dial that in to the ventilator and pay very close attention to that. Remember, when you're coming back down in elevation, then you'd have to adjust it again. There's other ventilators out there like the Hamilton, the Eagle, Eagle Impact, a couple other transport ventilators that will have altitude compensation. That's great. And you don't have to worry about it. But there's other things that you can do. If you put the patient in a pressure mode and watch their volumes, that should kind of protect you from a little bit of that. As we go up in altitude, remember our volumes expand. So as when you're doing that, you're like if you're going from 0 to 17.7, I think it is, you're just about double your tidal volume. So pay very close attention to that. You don't want to cause any injury, especially if you have a patient who's in ARDS and you want their volumes to be low. You want to make sure that you're not overdoing it and causing any more problems. All right, here's something kind of cool. Hopefully, we won't need this too much again, kind of like the altitude compensation. If you think of your PO2 at different altitudes, if you're at sea level, your PO2 on ambient, PO2 should be, 20.9 FiO2. That would be 159.21. Now that same room air and then you go up to say 14,000 feet. Now you've got or 15,000 feet, 89.88. So that's pretty significant drop in available oxygen that would allow to get over to your patient's blood vessels. So just be cognizant of that. Pay attention to what you're doing. Go up on FiO2 if you're going up in altitude, and to meet the patient's needs. All right, dad joke alert. This section might be alarming for you. Alarms are high pressure alarms. That's going to keep us from overpressurizing inside in the lungs. So to pop off, say if the patient's coughing really hard, and we don't want those peak pressures to be super high. If the patient's compliance is decreasing or their resistance is increasing, it's going to let us know that hey genius, pay attention to your numbers on your vent and make sure it's set correctly. So we're going to set 5 to 10 centimeters of water pressure above the patient's peak airway pressure right now. That will hopefully give us an idea that things are changing. Maybe there's secretions in the airway that are increasing peak airway pressures due to resistance. So we can suction them out. Maybe they're biting the ET tube. We can put a bite block in. Maybe we left the suction catheter down the ET tube and it's causing a resistance problem. Or just the compliance and resistance is changing. Low PEEP, that usually means there's a leak. The ventilator is going to do its best to maintain a PEEP if it can. So pay real close attention when you see that low PEEP one. High respiratory rate, we're going to set it 10 to 15 breaths above a stable rate. That gives us an idea if the patient is a little anxious, if they're uncomfortable, or if things are changing in their airway. Low pressure. Again, low pressure is telling us that you probably have a leak somewhere. So you want to make sure you're looking up and down for it. And we always tell people you can either go from the ET tube to the circuit, or the circuit to the ET tube, and figure out where it's at. Just do it consistently and be very systematic about what you're doing. Pay attention to everything. The more senses you're able to use on it, the better. So if you can feel it with your hand, then it's easier to locate. If you can hear it, it's usually one of those little caps that pops off, or your PEEP valve is leaking. It's got a crack in it. It's a loose connection somewhere. Remember, the FDA requires vents to have multiple alarms. They are annoying sometimes, right? Because one time you'll just connect the patient to do a procedure, and then you go to plug them back in. It's a beepity 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 beep. Well, it's going to keep beeping because it wants to have redundancy on there. It wants to make sure that you know that the patient is disconnected, and there's multiple different reasons why. So don't be mad at the at the ventilator companies are just doing what the government wants us to do. Our asthmatic patients are very difficult to manage on ventilators. Um, we have with asthmatics, we have a narrowing of the airway, which causes an increase in resistance, which causes a lot of air trapping as well. So the patient can't actually get the air out, and if we narrow the airway even more with an ET tube, it becomes problematic, right? So we try not to intubate them unless we have to. If we do, we want to shorten our I time to give them the ability to exhale as much as possible. Again, we're going to be giving our bronchodilators any treatments that we can that would manage them. And I'm not going to get into all that stuff right now. That's a whole nother lecture. We can do an expiratory hold on the LTV and Revel and NV. And that will give us an idea of how much intrinsic PEEP the patient actually has, so we can track whether we're actually doing good or bad for this patient. We can increase the PEEP as well to match their auto PEEP. And so why are we doing that? Why are we increasing the PEEP? Well, what that does is it helps helps the patient trigger the ventilator. So if we can match their intrinsic PEEP with PEEP, then we can allow that the patient to be able to flow trigger a little bit easier. Pressure trigger is going to be harder. Flow trigger is going to be a little bit easier. But unless you have something like NAVA, the patient's not going to be able to trigger the ventilator because it would have to suck back really, really hard to be able to trigger the vent. So matching their PEEP would allow that to occur. And then you can, as you do another expiratory hold, you're able to track where their PEEP is now, and then go back and keep dialing down as they get better. Alrighty, just heads up for the rest of the things that we're going over. I'm just going to go real light over those because they could be a whole lecture and by themselves. Traumatic chest injuries, if you think about those, it could be from an MVA, it could be from a gunshot, knife, blunt force, any of that stuff. We want to make sure that we're have good pain management. We're assessing for pneumothorax, hemothorax. And then remember that the patient's going to guard against inspiration if they have a lot of pain. So they're going to have a lot. They're going to forcefully do a higher respiratory rate with a lower volume, so to decrease the pain or lower pressure. So make sure you're controlling your peak airway pressures, but more importantly, your plateau pressures, and then keep assessing them over and over until you get there. Then you get a CT, MRI, X-ray, everything that's really, really expensive. Okie dokie. COPD patients, chronic obstructive pulmonary disease. Well, we know about them as they can't exhale. They're kind of similar to an asthmatic. We are going to do an expiratory hold to find out what their intrinsic PEEP is. We may need to shorten their I time even lower than what we did before, so we can blow off more CO2. They may need some bronchodilators. Almost just said all wrong stuff, but and they may need their bronchodilators to help open up the airways to allow them to exhale a little bit better. And know what your correct target for your blood gas would be on this one. Remember, if they have a bicarb of 35, is their CO2 going to be 35 to 45? Well, no, it's not, right? So then you want to target what it is that their their pH normally would be. Hopefully they have it in a chart. Hopefully the family member knows, or you can kind of guess or calculate off of your bicarb where they would be. Avoid intubation if possible. Try BiPAP if you can. Now in these, like where we are right now with a viral infection being very popular, BiPAP might not be a great idea at all, because now you're going to particulate, especially if you're in an ambulance, you're going to particulate that all over the ambulance. And yeah, even with a really good mask, you're probably going to be breathing some of it in. So be very careful. They're coming out with a very high flow. If you have a nasal mask, they're going to be exhaling through their mouth. If you have a full size mask, it should decrease the amount of particulation. But you have a whisper valve on there that's going to blow it all over the ambulance and the airplane, or wherever it is. So just be very careful about what you're doing. Make sure you're following your guidelines from your hospital. All right, we're almost done. Do yourself a favor, open up that Pulmonetics manual, or Viasys, or whatever age related ventilator you have. Go through the manual, know what the strengths and the weaknesses are. Every ventilator has a strength and everyone has a weakness. But the practitioner that doesn't know what those are, they are the weakness. So know what you're supposed to be doing, how to do it, and hop on their website. There's some videos on there on how to do things. It's only going to make you better. This crisis situation right now, we want to make sure we're still providing excellent care for our patients, so we can get them off the ventilator and put somebody else on there that might need it. All right. Well, I'll talk to you guys soon. Call me with any questions. You can email me at justinmizuraka@yahoo.com. That's justinmizuraka@yahoo.com. I know I need a new email address. It's old, but send me a message if you need, and if you see anything that needs to be corrected or adjusted, let me know and I'll